Sawadika and good morning. Everyone's on Saturdays. Hope everyone stays safe and healthy. My name is Sudasamon Fusili, Training and Education Managers from Medtronic. Welcome you all to the Apmbss A to Z webinar series. This is the episode 3 already. Hope you enjoy our sessions, and before we start, please be informed that if you log in as a participants or attendees, you will only see your names and panelists, and your light will be muted to avoid the distortion. But you can still ask your questions by typing via Q&A box or raise your hands to give you the questions, and then the panelists and the faculties will answer the questions. And for the chat box is for general communications such as greetings or suggestions. And this webinar will be recorded. And for the privacies and disclaimers, we have requested all the participants, please do not take photo, screenshot, or record this event. Thank you. All right, today is a great honor to have a lot of seasoned faculties and panelists with us to share their experience and the discussions. First of all, may I introduce our course director, Dr. Suthep Udomswangsap. He is a director of the July Minimally Invasive Surgery Centers. He is the president of the ELSAS, the president of the LES, Apmbss, and TSMBS. Please welcome our Dr. Suthep Swangsap. สวัสดีค่ะอาจารย์เรียนเชิญค่ะ
สวัสดีครับ Thank you very much, Ms. Fusili, for the introduction. Good morning, everyone. Thank you very much for joining us. On behalf of Apmbss, I would like to take this opportunity to welcome all of you to the Apmbss A to Z webinar series. And this one is going to be episode 3. And also I would like to introduce to you, and I would like again to express my gratitude to our founding president of Apmbss, Professor V. Lee. Thank you very much, Paul, for joining, especially for your leadership and your initiation for this field of the bariatric surgery. What I would like to inform you is that we can see that Professor Lee has been published so many publications and also guidelines, as well as the scoring. As you may know, that ABCD score has been very much helpful for us to predict or to choose the procedure and also choose the patient match to the result. Thank you very much, Prof. Thank you for joining, and also thank you for your leadership. Next, let me introduce to you our own good friends, and for a long time friendship that we've been together. We are working very closely because Professor Ramesh Gulanathan, he is the president of MUJIS, or the Malaysian Upper GI Surgical Society, and also he's a vice president of the ASEAN Upper GI Surgical Society. I has been working with him for a long time. Thank you very much, Ramesh. Thank you for your collaboration and contribution.
Thank you so much.
Next, a good friends, we're being together, working very hard, doing academic and also the contribution to many societies, especially on the field of bariatric and metabolic surgery. Let me introduce to you Asim Shabir from Singapore. Thank you very much, Asim. Thank you for having your time with us. I know you are very, very busy and also very academic. So today I would say that all participants would be having an entertainment from the academic discussion that we will be giving to you. And also I would like to thanks teams for preparing the cases, because the A to Z series will be specifically discussing about cases, and today will be the inter-op challenges, which It's one of the most interesting. We would love to learn from others, but anyway, sometimes we experience ourselves in the same situation, so that this seminar would be very beneficial to everyone. Let me introduce to you Dr. Pakawut Chansawang Puwana from the Department of Surgery, Faculty of Medicine, Thammasat University. He also the director of BMI at Thammasat University. Thank you very much, Pakawut. Next, it's one of our very talented surgeon from the south of Thailand, not far from Ramesh and Azim, is Kamthon Yong Suriyawong. He is the head of MIS unit, Department of Surgery, Songkhla Nakarin Hospital, Prince of Songkhla University, down in the south. Thank you very much, Kamthon. Next, I would like to introduce to you Dr. Walabut Tawi Ruchana. He is the Chief of MIS Unit, Department of Surgery, Faculty of Medicine, Sirat Hospital, Marihiron University. We already knowing him very much. He's very talented, not only in the field of medicine, but also a talent in other fields. Thank you very much, Walabut, for joining.
Thank you very much, Professor Satep.
Thank you very much.
Hello to all the Professor Lee, Professor Ramesh, and Professor Asim, and also co-panelists. And greeting to all the online participants today. Thank you very much.
Thank you. We'll be joining your presentation and also your discussion, your point of view from the case that you will be presented. Next, one smart surgeon that I would like to introduce to you is Dr. Narong Bunyakat. Narong is from Krang Hospital, actually the Bangkok Administration Hospital. Narong, thank you very much. Thank you for having your time with us. So today we will be discussion about inter-op challenges. So that I would say that one of the most interesting is how can we deal with the situation? As we may know that if we can deal with the inter-op situation well, post-operative will be not too difficult to deal with. So that today we will bring to you our mentor advices. Then in case that we experience that, we'll be having ability to have the patient safe and benefit from the procedure. So that I think before we getting started, let me also take my gratitude to all support, especially for Medtronics for supporting these webinars. And please follow us at Apmbss A to Z. It's going to be monthly webinars. So last but not least, I think I would love to have Professor Lee to give a little bit some word to the participant before we start the first case as the founding and the leader and the master in this field. Professor Lee, please.
Good morning, everyone. Good morning, Sutep. Thank you for your wonderful language. You are too kind. I think you have contributed a lot to the training and working of bariatric surgery in Asia, especially in this COVID-19. You can launch this Apmbss webinar. I think it means great things to all the young surgeons in this field and will be help for continue promoting bariatric metabolic surgery in this field. I would like to thank all the team in Thailand. Thank you very much for the hard work. And again, congratulations, Sutep, again. Thank you.
Thank you very much, Prof. Lee. So I think everyone has been waiting for the advices from our mentor. So let's start for the first case will be presented by Pakawut and his team. Before we getting started, let me introduce to you here, I think we got a good friends from Australia. Ken Loy, thank you very much for joining us. Ken, good morning and thank you very much.
Good afternoon.
Oh, actually, good afternoon to you.
Yeah, Thank you for all my good friends. I'll be just listening to the great history and chipping my comments. But you guys have done great work, so congratulations.
Thank you, Ken. Thank you. We are very happy to have you. We always having some surprise to our participant. So today we are very happy to have you. Thank you very much. So let's have first case will be presented by Dr. Poon, a team of Pakawut from Thammasat University. Poon, please start the first case.
Good morning, everyone. I am Dr. Poon Wangwisawawit. Today, I present you a 38 years old obese man, BMI of 45, with type 2 diabetes, hypertension, dyslipidemia, and OSA. Preoperative EGD found gastritis with co-test positive. After H. pylori eradication, we performed laparoscopic sleeve gastrectomy. In operation, we found that he had massive hepatomegaly. We inserted the camera port under direct vision, the Apmbss Qa fascia, abdominal sheath, muscle, peritoneum. Then we found liver surface at the trocar tip, as shown in video. So what would you do? Please make a poll.
So you are welcome to join the poll, so you can choose
Stop operation or continue operation with standard technique. Move camera port downward, move pause downward, and use extra long instrument or the others. Please vote. Thank you.
Thank you. I think we have, can we have the result of the poll? So Poon, you can analyze for the result.
Okay, the poll result was mostly choose that move camera port or move out the port and use extra long instrument is 30%, around 30%. Okay.
Thank you. I think, yeah, the advice from our participants, our team would be number 2 or number 3, moving port downward a little bit or continuing the procedure with the same technique. So we have the advice from our specialists. So I think we're gonna start from Azim. Azim, I think you would say that we should be having a good or better preparation for the patient. But anyway, at this point, what your advice?
So yeah, certainly. I think I'm a very big proponent of the fact that the patient needs to be prepped properly. I think no literature today has shown the benefit of preoperative weight loss to patient. But I think we have never attempted to show the benefit of preoperative weight loss to the surgeon, right? And this is exactly where we faulted, right? So a liver that could have been easily been shrunken and we could have had such a smooth surgery, we made it complex for ourselves. So that's one. The other comment I had, I do not know how far away from the midline and how far away, where exactly is this port being inserted. So that would be something that I would like to know. And last but not the least, if we look at different cannulas, starting with the ones from different companies like Medtronics, like from Johnson & Johnson, Applied Medical, the portion of the stylet that goes in varies. So different people have different, and different tissues give you different resistance as you go through tissues. So now what I tend to do is once it passes a little bit, you have enough an opening in the peritoneum, I actually remove the stylet and inflate. it does not create subcutaneous emphysema or anything. And once the abdominal wall is lifted a bit, then reinsert the stylet and just screw it a little bit. It prevents injury not only to liver, but to peritoneum, to mesentery, to small bowel and all the structures. So I think those are some of the comments that I would like to make. And I think somebody made a comment that we need to use extra long trocar. I 100% agree. Thank you, Suthep.
Thank you, Asim. Thank you for the techniques that you advise. So, Lamesh, you are IVR,
Yeah.
so what would you recommend?
Yeah, thank you, Dr. Step. Actually, I tend to follow exactly what Asim says. The way the procedure of these trocars are inserted. I also actually go up to just to the peritoneum, make sure there's a tiny hole, and then once you inflate, you've got so much of space. I think the liver falls off, the bowel falls off, and then you reinsert the trocar again, and then you know exactly where you are. So this, I think, most of the time is very, very safe, instead of immediately putting the trocar right into the abdominal cavity. So I think that's a very safe procedure, which maybe, if you've not, those who have not tried should actually do it, because then you avoid surgery, injuries to the liver, which, in this case, which might have happened. And I agree that, the proponents for losing weight before the procedure, so assessment before surgery is definitely very, very important. Yeah.
Thank you, Ramesh. Professor Lee, please have some advice to Poon for the next step.
I think now the standard technique is advised the first trocar, video trocar play in 15 centimeter around below the xiphoid process. So you might meet this situation. So my standard technique is still use the Apmbss for the first video trocar. So when you have this situation, so my advice is you should put another trocar in the lower, in the Apmbss. It should be very easy and to control the situation. Yes, that's similar to Ramesh and Asim. Yes.
Thank you very much. I think, Poon, the advices are getting a bit lower, especially if you have detected before the operation that the liver was very large. But anyway, you already there inside, but good that you detected at the beginning that the liver was in front of you, and then you just stop and then ask for the advices. Ken, have you experience like this in Australia? I think you may have some experience to share. Thank you, Ken.
Yeah, I think I only stopped operating once because the liver was too big, but you always can put the port lower. I use 5mm camera, so it's not as big, and I use a port that got a little hole on the tip. So when you enter, you can already have a pneumoperitoneum. So it's easy to put another 5mm port, maybe about 5 to 10 centimeter below what you originally put in, because at the end of the day, you got to see if the liver can be lifted up. If you can see the cardioesophageal junction, then you have an operation. If not, then I think it's not safe.
Thanks, Ken. So you told us that you have a board one operation because of the liver. So number one, stop operation. That's depending on experience and situation. So in your case, what make you decide to quit from the operation?
Because I think you also, not when you had a big liver like this, you probably have portal hypertension. And then once you go in, if you've seen a lot of collateral veins that is big, you know that it's going to be increasing venous pressures. And I think it will be quite dangerous to operate on patients with severe portal hypertension, because even though it's only sleeve, of course, bypass even more dangerous. And everything you touch later on is going to bleed. And you probably need to optimize the patient with a shunt or TIPS procedure before surgery even.
Thank you, Ken. So I think even we get started into the third part, And your advice that if experience is not there and you try to get in and see the liver is too big, you may put a small port lower, and then you can evaluate inside, especially the function and the portal pressure. So also one of the most important. Poon, what you have done and what I'm sure that you have checked for the liver function already. Could you please proceed for the presentation?
Okay, thank you for all good advice. In this case, after we found liver, we pointed the trocar to patient's leg, then go to lateral. When we saw liver and gastric wall, pneumoperitoneum was created, and the left lobe of liver was shown and huge and cover entire stomach, extend to umbilicus level. After that, we inserted Nathanson retractor and try to retract the left lobe of liver gently. So now we have a good exposure and no portal hypertension. The stomach look good. So we decided to continue the operation. We inserted the instrument port at right upper quadrant and left upper quadrant. Then we continue to perform sleeve gastrectomy without complication in this case. Thank you for your advice and your attention.
Thank you, Poon. Thank you. Congratulations. Ramesh, any follow-up for the advice?
Yeah, I think what he did was really good as what pointing the trocar towards the foot end, which is, I think, very safe because although the umbilicus reached the the liver reached the umbilicus, but pointing it towards a safer area is the most important way to avoid puncturing the liver, which will be a disaster, and that would make you end up stopping the operation. Yeah, so that's a good point which he showed just now. Yeah.
Thank you, Asim. Your comment on what Poon and Pakawut team has overcome the situation.
I think yes, I agree. What they've done is probably one of the choices. Dr. Poon, if you don't mind, could you just unshare your screen, and I'd like to just pop up something that I would like to make a point about. So liver injuries are not that common. Not only the fact that we injure the livers during bariatric surgery, but upper GI surgery, we do injure it. And if I were to share a diagram to show what I wanted to mean about what I'm saying, then this is the diagram. All right, so if you look at the segments of the liver, the hepatic veins and the portal vein distribution, when the liver enlarges, it is this inferior margin that enlarges. So essentially what you go and do with the trocar is you basically create a big biopsy in there. Now, what we need to learn is how do we stop that? Do we just take Surgicel, stuff it, or burn it, or whatever we do? How are we going to control that? The likelihood that these blunt trocars will actually injure a major tributary of the hepatic veins or the portal vein is almost close to 0.0001%. So I mean, in times of dire emergency, keeping composition, and I really appreciate Dr. Poon and team for keeping their composition, moving the trocar away, but just pulling the trocar out, blowing air a bit, and then looking at the damage, assessing, putting extra trocars can sometimes help. I've had sometimes injuries to the liver. Take a Surgicel and just pack it, and it generally stop bleeding. I do not know what the rest would think, but I think putting up the trocar at a newer place, as Dr. Poon and team did, is perfectly all right. It's just that if there is blood in the field, once you have taken out the top trocar and gone to a new place, then some of the younger surgeons may get very, very scared of massive bleed inside. And even before they put their camera pots, they will have opened up the patient because they have thought that they have actually called. And to reassure them, liver is a very forgiving organ. It has a tremendous healing capacity as long as you do not repeatedly insult it, okay? So it will bleed a little bit, but will calm down relatively easy if you handle it with tender, loving care. So just those comments. Thank you. Thank you, Sutha.
Thank you very much, Asim. Thank you for showing us the anatomy, especially the incidence of injury to the major vessel. It's not that high, so that if in case that you got facing to the bleeding from liver injury during the first part, stay calm and try to control the bleeding, which will be stopped. That's also very important to keep in your practice, in your mind, that in case you're facing that situation, don't rush, just stay calm and try to control the situation. So anyway, thank you very much, Asim. Professor Lee, any advice to add for Poon and team?
I have one feeling. I think the surgeon do a good job, but you looks like use the original video trocar to finish the operation. So it looks like your video is above the lower margin of the stomach. I think that will be quite uncomfortable for me. I think an operation, especially for sleep, the instrument should coming from at least the lower margin of the stomach, so you can control the whole anatomy. And you want to use the original video, so it looks very high. So I think next time you can put another trocar at lower side as a video to finish the operation. That will be more comfortable for the surgeon.
Thank you for the advice. Yes, I think Pakut and Poon, you entertain yourself with the video, the camera that it's a bit higher, that as Professor Lee has been mentioned about. But anyway, Ken, anything to advise for Thammasat team?
I think the issue with liver bleeding is you have to stop the bleeding before you put the Nathansons in, because once you put the Nathansons in, you're essentially creating a venous congestion, so it will bleed more if you don't stop it. I mean, I guess the first thing I use is gauze and Raytec, and that might be enough to stop the bleeding and mop up the blood, because once you have blood, the vision, it will absorb the light, so you can't see. So you have to clean up the blood, or maybe put pressure on it and get them to open a suction irrigation, because I don't usually use suction irrigation because it doesn't help. And some of the bleeding, if it's more ferocious, you can actually put in like a 4 inches vaginal gauze pack, which give you a lot of Raytec ink to put pressure on to absorb the blood. Because the main thing is, us all the other panelists say, don't panic. Liver is all the bleeding eventually will stop once the 5 liters of blood run out, but we don't want to wait for the 5 liters. But I think once you absorb the blood, put pressure on, like open surgery, you have time to sort out the bleeding. And I agree with Professor Lee, the port was a little bit too high. Unless the surgeon is very tall, like Sutep, then it's going to be very uncomfortable for the shoulder.
Thank you all for all advice. Poon and Pakawut, anything to respond to the advices? Pakawut, please.
Yes, thank you for any comment. Usually, I think when I met this situation, I think about the extra port that everyone mentioned it, but I first step I try to do pneumoperitoneal safely. I try to bend the camera to the safe direction and try to create pneumoperitoneal first. Usually, in this case, I see that for the liver is big only the left side, the right side is normal. We have space on the right to do the operation. So the problem, our problem is the left lobe liver. So I try to put the Nathansan to retract, and I see it's have possible to go on operation. So I move the Nathansan port down maybe 2 centimeters and lift it gently and go on operation. I agree with everyone that it's very tough to do this operation and feel uncomfortable like you mentioned. But I think when I mobilize the greater curvature, it have some mobile of the stomach that I can do operation. Thank you.
Thank you very much, and also congratulations that you overcome the situation and having the patient through the operation safely. Thank you for your expertise that you're sharing to us. Any more comments regarding liver size and the situation of liver bleeding? So,
Professor Suthe, may I ask a little bit, please?
Please, Walabut, thank you.
Yes, thank you very much for the great presentation from Dr. Pakawut team. I would like to ask all the experts here about the first pod. I mean, the camera pod. What is your location of your camera pod? I personally, I get into the belly by varus needle, and once the hemoperitoneum achieved perfectly, and then I'll put the first trocar around 18 to 20 centimeters away from xiphoid and just to the left paramedian area. So how about your suggestion?
Asim, please, any response to this issue?
Yeah, so I guess there is no one way of putting your ports, right? Some of us in bariatric surgery will get people where the tummy looks like a drum. It's really round. There are others who have a gradual pear-like belly that is just lingering on down. So I think it's very individualized. This 15 to 20 centimeter is a gauge. As Prof. Lee said, if you start at 15 centimeter, you may not reach the greater curve of the stomach, and then you're operating with the hand like this and curving and doing that, which is not great. For people doing Roux-en-Y gastric bypasses, you put it very high, then suturing the defects, it's very difficult. But for OAGBs, it's nice to keep it high. You can get to the hiatus, do whatever. All you need to do is pull the loop of bowel. So it really depends. And I think we should tailor the port placement. And for a bariatric surgeon, access is something that is extremely important, and we should not rely on one technique. We should be proficient in using Veress needle. In obese people, having access through open Hassan technique, and at the same time using different trocars, comfort zone, because you will have people with 4 laparotomies coming for bariatric surgery. You won't just say, okay, I'll do an open surgery, right? So I think, and your colleagues will look up to you, and when they have bigger patients in MIS surgery like gynae, ops, and other people, they will come and say, can you help me put the trocar? You are very familiar. So I think it's really very dynamic to me, and I really love that experience. That's my comment.
Thank you, Asim. The technique of using Veress is also very much safe and effective in preventing any injury. Professor Lee, you mentioned about the umbilical port and also the 15 centimeter downwards. So anything to advise for the first port?
I think Asim is right. There's a different situation, so no standard technique. So you should follow what you're most comfortable, but always need to put more trocar if need. So for our technique, we use Veress needle and we go from umbrix because it's most thin part and you can control all. So we don't make liver problem, but we do make some. I think my colleague made one pregnant woman. When you put the first trocar, you put it into the uterus and see the baby. It's really scary. And I personally do one push into, you see the huge ovarian cyst. So you put into the ovarian cyst. So if you come from the umbrix, something you may met is from the pelvic. And if you put too high, like this case, you will make the liver and probably go too high. So you have a situation when you choose one technique, but I think it's okay for every technique. Yes.
Thank you very much, Professor Lee. Thank you, Asim. So we start for the first case, also very interesting case. for the entry into the abdomen, which is very important. It's been said that at the beginning point, it's also very important to predict the result or the difficulty or ease of the operation for the next. So thank you very much, Pakawut and team, and also the advisors. So we move to the next, but still, I think talking about something that when we get in and then we having the diagnostic laparoscopy as we always doing, and then we found something and what we're gonna do next. So please welcome Dr. Aisawan to present for that second case for the discussion. Aisawan, she is working here at Chulalongkorn University. Please.
Okay. Thank you, Dr. Steph, for warmly welcome me. Okay. This is the second case, the interesting case. Okay. This is a case of 60-year-old woman. She has a BMI 60 kilogram per meter square. Her comorbidities are type 2 DM, hypertension, dyslipidemia, and NASH, cirrhosis type A. Her liver function test is normal, and her platelet and coagulogram is appearing normal too. The EGD is unremarkable. There's no any gastroesophageal varices, no gastritis. The imaging, the CT scan shows liver cirrhosis, no collateral vein, no ascites, and no splenomegaly from the imaging. Okay, we proceed to the poll. What would you do in the 60-year-old female with BMI 60 with NASH, cirrhosis type A? First, lifestyle modification only because she's not the good candidate for bariatric surgery, or intragastric balloon. Or you will perform the endoscopic sleeve gastrectomy, the laparoscopic gastrectomy, or laparoscopic Roux-en-Y gastric bypass, or the other. Please vote.
Yeah, please join us for the voting. So I think last episode, the episode 2, we have been discussing about pre-operative decision making and the preparation. So now let's check what we would advise for Aisawan for this case. Okay, so I think we have the result. Aisawan, please review the result.
Okay, mostly participants recommended laparoscopic sleeve gastrectomy. Okay, nearly 70%. Okay, we will continue. So the problem in this patient is the liver cirrhosis. And when we put the camera pot, you will see the liver, you will see the nodular surface on this liver. Okay, so any intraoperative suggestion from panelists? Please recommend me.
So let me start with Ken. Ken, please, you are liver expert too.
Well, I think this is exactly the time that you need to decide if you can offer safe surgery. If your Nathansons can actually be lifted up successfully to see the last shot. We call them the last shot because that's when the leaks happen. So, you know, and that's where the most difficult vision is. And if you cannot see it safely, I don't think it's safe to, you know, sort of proceed with the surgery. But I mean, I think it's in a female patient. Looks like you still got plenty of room with the pneumoperitoneum. And if you stand the patient up, I think this operation still can carry ahead. But I would probably put the patients on a little bit of extra Optifast for 4 weeks. I know Asim commented the literatures that there's no proven that preoperative weight loss will improve, but I think there will, as much as you can shrink the liver, any centimeter count. I think, you know, it's about visions and also safety. And I would like to know if there's any other comorbidity besides the liver problem, because if you have 2 or 3 organ problems, then maybe sleeve gastrectomy might even not be safe enough for this patient. So cardiac and kidney and lung is something that I'm concerned about.
Yeah, thank you, Ken. Lamesh, I think you are both a bariatric and upper GIS, so you may experience situation like this. What your recommendation?
Yeah, my concern is the cirrhotic liver. Yeah, although it's child's A, I guess it's not the worst of the cirrhosis. I think the other problem sometimes, which I have faced with some patients, is when you actually apply the Nathanson's retractor. No, if you don't do it properly, that retractor can be a problem to the liver. So when you actually retract using Nathanson's, I think there are times when you may injure, and again, you may think that the bleeding from the liver again will cause you some difficulty in the operative field. So I think like what Ken says, every inch of, if you can bring down, the liver, that's going to make things much better, more easier for your operative field, and you prevent further complications. This patient already has cirrhosis, already has diabetes. You don't want to push this patient into, child's B after, the surgery and all that. So I think these are the things which needs to be considered before going ahead with the surgery. Yes.
Thank you, Lamesh. Thank you for your advice and concern. So, Asim, I think, there are so many considerations that you may have to put together for decision making. Liver retractors also. For Lamesh, I think Lamesh, you use a Nathanson, right?
Yes,
as well as
Nathanson.
Ken. Yeah. Asim, any advice on that situation?
I guess if you look at a cirrhotic liver and look at NASH liver, a NASH liver is largely studded with a lot of fat, but it is still quite supple. It is soft. So you can use the retractor and mold the left lobe in the shape you want it. Whereas a hard cirrhotic liver is not easy to mold. Every time you put the retractor, whether that's a iron intern, whether that's a Dickinson retractor, whether you put the whatever malleable retractor, whatever you put inside, will not sit well on a contracted left lobe of liver. So all you need to do is just hitch it away gently from your thing. What you don't want to do is put the liver retractor in such a way that it actually cuts through like an apple core, right? A cirrhotic liver is really like an apple. Once you just do like this, everything will just split open, and it is very hard. So be very careful, because hemostasis is very difficult to achieve. What you don't want to do is compromise whatever little liver you have now left. Sorry, can I just come back again to Aisawan? Is this child's A cirrhosis or B cirrhosis?
This is child cirrhosis.
Child's A. So
yes.
I'm not too much worried about patients with child A cirrhosis. I mean, as long as the liver functions are okay, you're having somebody who has 60 BMI. You leave this patient alone with 60 BMI, the NASH will continue to progress. This is not likely patients who are suffering from hepatitis B or hepatitis C. It's likely a NASH-related cirrhosis, which we can see. So if you leave this patient is not going to make it. The only valid chance we have is to offer weight loss, which is about 10 to 15%, which will give this patient the best bet to survive. We can go on discussing about bypass versus sleeve gastrectomy. I mean, one way or the other, you're going to disconnect your varices. The portosystemic shunt that happens at the gastroesophageal junction, you're going to take it away, right? Whether you do a sleeve gastrectomy or you do a Roux-en-Y gastric bypass. But if you really want to give this patient a good fighting chance, a bariatric surgery is something that I would consider. Yes, comorbidities wise, I would look at diabetes, hypertension, hyperlipidemia. But again, with 60 BMI, and not so chronic diseases, I would take the bolder step of moving in and giving my patient the best choice. Comfort of surgery, choice of selection of surgery will depend on the surgeon's comfort level. How comfortable are you doing a bypass? Do you want to, how comfortable is your anesthesia team with it? I mean, I personally don't do bypasses on 60 BMIs, not Ru and Y, because the pouch is so high unless they're properly prepped. So I would do a sleeve. But if I can get a very well prepped patient where I can move the bowel up to the pouch, well, why not a bypass? I don't see a reason. So thank you.
Thank you, Sim, for the point of discussion, especially the operation procedure of choice. We have to have advice from Professor Lee for this situation. Prof, please.
I think when we go inside the liver, it's quite scary, but actually for a 60 years old patient, I think this kind of liver is quite normal. But I must point out, so-called trial A, more important is you need to look at the albumin level, which did not show in this slide, rather than bilirubin, because bilirubin is for a B. And I suppose the albumin level should be greater than 3.5 in this case. But however, when we look at the patient, we need to look at whether it's beyond 4 or below 4. If above 4, actually is no influence in the liver function. So I will do my most favorite one osmotic gastric bypass. And if the patient albumin level is below 4, that's even is above 3.5, still have a great liver damages. So I probably only choose sleeve. And for Ru and Y gastric bypass, we just published our 5 years long-term data to look at the super obesity. We don't recommend the Ru and Y in super obese patient because the risk is much higher than the other two procedures. And the outcome were not better than sleeve alone in super morbid obesity. And so I personally think if the liver function is good, albumin level is adequate, above 4, I will consider OAGB because it's much easier than even you do a sleeve. And OAGB is a superficial operation. You only need to go superficial on the stomach. And for sleeve, in this case, I think it's still quite difficult. You need to go very low and the space is limited. So this is my thinking and comment. Yes.
Thank you, Prof. Your point is very valid and it's very beneficial. Asim, your recommendation is very suitable to everyone that depending on also the surgeon's confidence on doing the procedure. But anyway, for this one, let's see how ISO1 proceed for this situation.
Okay, we will start with the omentum from the greater curvature of the stomach until the inferior border of the liver. After that, we put the Nathan-Sun retractor. Okay, in this case, we put it manually and we gently lift the liver only when we perform the operation at the upper part of the stomach. Okay, we dissect along until we reach the EG junction. And once we dissect, okay, we'll put it down the Nathan-Sun detector and we perform a saber cutting the stomach. Okay, and we'll gently lift it again when we perform in the upper part of the stomach. Okay, and this is the final gastric. And we gently remove the Nathan-Sun detector from the abdomen. Okay, thank you.
Thank you, ISO1. Ken, you have seen what ISO1 has used the manual retractor of the river. So you're from Australia. What your recommendation on this point?
What I can see is I think you're all familiar with Nathan-Sun's. In fact, I think this is one of the most important thing in training, besides port entry, is putting in the Nathansons. I've seen people putting Nathanson, split the liver into half, tear the peritoneum, and this Nathanson's retractor actually is very big. So there's 3 sizes. So I guess in Asian patients, the costal margin is quite narrow. And if you put the biggest Nathanson's, that tip can end up to be a cardiac puncture or device. So I think you have to be really careful. But I agree, manually you can adjust it. The only thing good about the Nathanson is that once you fix it, they don't move. So I routinely do my sleep with 3 ports only. So I don't need my retract. I don't rely on the assistant only holding the camera. I pretty much use the, do it myself. But this might be the case that I would look at that, use a little Raytech and putting an extra port for my assistant to push the fat away on the left side, because the dissection will be important at the corner, because if you don't have a good vision, you either burn the esophagus and create a leak afterwards, or you get into the spleens, because you got very narrow space at the end. And whether you want to make sure that your last staple is clear of everything. But generally speaking, it's still good job, well done. But that's my, looking at the video, my comment.
Thanks, Ken. Thanks for the point that the Nathanson does have 3 sizes. The nose, the tip was very important. We have to choose. I think Isolan, you use the longest one I can see from the presentation. So anyway, Ramesh, any specific procedure, maneuver to carefully take care of the liver in this situation?
I think what the video showed was quite well done. The way the Nathanson is applied at the once she's crossed the liver border. So I think it's very safe the way it's put in. I normally use the medium size. I think most of our patients, the medium size is actually adequate to use for the Nathansons. Rarely we use the large, and like Ken says, for some of our patients, the costal angle is quite acute. If you use the large Nathansons, sometimes you find some difficulty, and for junior surgeons who've got lacking experience in putting the Nathansons, I think they have to be very careful in how you actually insert the Nathansons and how do you actually lift the liver with the Nathanson's retractor. But in this video, I think it was quite well done. Yes, thank you.
Thank you, Ramesh. Thank you. Next, Azim, any comments for the procedure?
I think very well done job, first of all, nice and smooth. Just something that I feel, I think we use gravity less to our advantage. All right. One of the biggest thing is, please secure your patient nice on table. It's very hard to operate somebody who's morbidly obese flat like this. Use gravity, push the patient like this, and the best of the stomach will come to you. You do not have to go to the stomach to receive it. Okay. When you tilt like this, the liver, which was covering your stomach, moves away. So as Ken said, you get your greater curve nice right in front of you. You actually do not even need to maneuver the liver yourself, because you can see the gastroesophageal junction very nicely. So use this to our own advantage, because it helps us achieve a better goal. Rest, I think it's about a good, nice, smooth surgery. Not necessarily the fastest in the world, but should be fast enough. Shorten your anesthesia time, because your post-op recovery would be smooth, and patient will recover well. That's about it. Thanks.
Thanks, Asim. Perfectly, we need to have your advice, please.
Very nice operation indeed. I think Asawan is a very good surgeon. And I must confess, I never used Nepson liver retractor in my life. I don't like too big. So I only use when I go outside operation, and I always ask my host to put a napkin for me because I cannot use this giant mic. And my gut feeling for one, I want to also hear the other experts. I think the sleeve is quite big for me. In the video, I don't see you even test the buji. You just live quite far away to do the operation. So this kind of sleeve, I'm wondering you maybe need to a second stage operation in the future. Yes. So that's is my gut feeling. I want to hear about Ken and Asin or Ramesh. What's your feeling about?
Please advise ISO1 for the size of the stomach and the sleeve. Please, Ken.
Yes, I usually will resect the antrum because with the stapler, even my second port, which is the 15 port, usually is around near the umbilical region, either up or down, depending on the distance. The device usually allow you to have 45-degree or about 75, sorry, it's about 45 to 70 degree of torque. So I usually excite some antrum in my first shot as well, just to reduce the volume. And in fact, leaving the little bit on the incisura a little bit bigger, so you don't create a pressure area. And then the other bit have to be a little bit tighter on the top, but not to the esophagus. So yes, it could be a little bit smaller, but sometimes maybe you worry about bleeding. You leave it a little bit bigger and then you oversew them. So maybe you leave some space as well. Yeah, I think for 60 years old with BMI 60, if they can lose, 30, 40 kilo, there it's all about, improving the comorbidity and get the surgery done safely. And the next revision surgery can be done if the patient develop further problems. So the main thing is get through the surgery safely, have a live patient afterwards.
Thank you, Ken. Thank you, Professor Lee, for leaving this issue. So I promise to teams that we're gonna do the next, probably after having our webinars on this. The next one would be post-op. Then we're gonna have some standardized or some techniques. So then we can discuss more in detail for the techniques of sleeve or other procedure. But anyway, Asim, you're here, and Professor Naito Takeshi, Ohio gozaimasu, you have a question to us that you're concerned about the blood supply to the liver, especially in cirrhotic. So Asim, Professor Naito, it's very much concerning about blood supply. So what your recommendation? He said that he's gonna use snake with the silicone disc to prevent or to protect the liver from ischemic situation. Asim?
Yeah, so the liver, only about what, 10 or 20% of the blood supply is actually hepatic artery. Most of the liver is fed by hepatic vein, portal vein. 80% of the hepatocytes are supplied. It does not take a great deal to compress them. So as we said, the only advantage of using fixed retractors rather than snake retractors is that you don't have to keep moving them. And as we said earlier out, you don't have to congest the liver if you place your retractors properly, right? So mostly it's how you angle your retractors that determine. What we try to do is because when we put the retractors of different choices, and if you make the wrong choice, the belly of the retractor actually pushes the anterior abdominal wall down, and then your camera cannot see. Then you try and force it more up and down, and that makes the trouble. So if you put the thing, as somebody earlier pointed out, just at the border of the liver and just gently anchor it, that's all you need. You just need to see where that angle of his is, right? Because your left hand is coming from here, it will never collide with the liver. and the right hand coming from the belly button or from the left hypochondrium, it will not collide. All you need in a sleeve gastrectomy is to see that angle of his. You don't have to open the entire left lesser omentum as well. And the last but not the least common for all of us who put large liver retractors is, you know where the falciform ligament is? We just saw very nicely that falciform ligament. Please do not put your retractor blade in there. What most people try to do is put it in there and hitch the liver up. If you do that, you are 100% guaranteed to cut off the blood supply for the left lobe of the liver. So always the retractor on the visceral surface of the liver, away from that groove of the falciform ligament, and you will never cut the blood supply off the liver.
Thank you very much, Asim. So very interesting discussion. So Aisawan, anything to say before we move to the next?
Okay. Thank you for every kindly recommendation. Okay, I will improve my surgical skills. Okay, thank you very much.
Thank you, Aisawan. Thank you, Aisawan. So let me have Kasunori Kasama is with us. Kasu, thank you very much for joining. So you're big fans of us. You are in the panels for every webinar. Thank you very much, Kasu. So we keep the next discussion for you, Kasu. So let's move to the next. After having the diagnostic laparoscopy and have found the situation and you manage it nicely. So then have a look during the procedure, something happening, what we gonna do. So let's have Naranon to present for the next case. Naranon, please. He also working here at King Chulalongkorn Memorial Hospital. Naranon.
Thank you, Professor Sutep. Good morning, everyone, all panelists. For the third case, is a 45 years old woman with a morbid obesity. Her comorbidity is diabetes and hypertension. So she was appointed to lap sleeve gastrectomy. So we'll see in this video. So after we divide the omentum from the greater curvature at the proximal fundus near the short gastric vessel, active blades of the sealing device. As you see, the fundus is near to the short gastric vessel. So the active blades accidentally injure to the spleen, as you see, and this go to the active bleeding.
Okay, you can stop here, and then we're gonna have the advice from the special. So Lamesh.
Yes. Yeah.
Okay.
Very scary.
Sorry, we have a poll. So
okay.
Naranon, please follow this. Yes.
So what should we do next in this situation to handle this situation? For the first, use a gauze. Second, try to use a sealing device. The third, use the argon plasma coagulation. And fourth, a splenectomy and others.
Thank you. Can we have the result? Naranon, please show us.
So
most of the advice would go to using packing and then probably using the sealing device. Please follow for the next what you can deal with this situation, and then we have the advice from our specialists. Let's have a advice from Lamesh first.
Yeah, thanks, Sutep. Yeah, so very scary video. Yeah, some of us actually have experience with this. Now, just like what, if you remember earlier, Asim said, like in terms of bleeding, how the liver is a friendly organ. To me, it's the opposite with the spleen. It's a totally unfriendly organ when it comes to bleeding, especially when you have need to do these gastrectomies and all that. Now, I think the first issue when I saw the video was, I think, the hot blade of your instrument. I think it is very important to actually place the hot blade away from these organs, away from the spleen, because I think that's the first step which you need to do to prevent disasters like this. The other thing is, when you have a bleed from the spleen, I think instead of blindly trying to stop the bleeding, the best option would be to actually try to visualize in which area is the bleeding coming from. So proper suction and trying to identify the exact spot would be the best option. Take your time to actually find the bleeder and try to stop the bleeder instead of rushing with the surgery. I think some young surgeons might think just putting pressure alone and then going ahead with the surgery is the best option, but I still feel that if you can actually stop the bleeding and take your time, take a deep breath and go ahead to apply some pressure, and if your bleeding stops, fine, then you go ahead with the surgery. Otherwise you would need to actually find the exact source. So good suction and finding the spot, that would be the best first step to do. Yeah, thank you.
Thanks, Ramesh. Very valuable advice that just have the compression to slow down and stop the bleeding, then start dealing with the bleeding point precisely. So this is a keyword that I would say are very important. Thanks, Ramesh. Let's go to Ken. Ken, what should Naranon do?
I think this is the time to take your own blood pressure and pulse rate first. That's
exactly.
That's very important. Don't panic, as we said. I think, as I say, I'd use only 3 ports, but this is a time that I would compress, ask for an extra port, put in the either sponge or vaginal skull pack, something big, to ask my assistant to press on it. Usually it will stop, but looking like this is exactly won't stop. There's only 2 comments that I usually will do beforehand. I will make sure that my anesthetist empty the stomach completely, including air or fluid, because this will help you to determine or better handle on using the grasper on the stomach. In fact, I use only bipolar device. I don't use the ultrasonic device, but yes, I understand it can be used. But this situation is exactly what happened. You have to actually go from underneath the stomach first to approach it towards where the vessels is. Then you can lift up the stomach to identify at least the underlayer of the stomach is not attached to the spleen. Then you can access and very close. There's only small distance between the vessels and the spleen from this case. So as Ramesh say, spleen is not friendly. I'd rather you cut the stomach and leave a little bit of stomach behind, rather than, and then you can sew it up or whatever it is, because the stomach is going to go, so the spleen will have to stay. If it's really too close together that you cannot separate them, you rather leave a tiny little bit of stomach there. I'm not saying leaving a lot, but I think that would be the strategy. But most of the time, if you employ the strategy, you should be able to divide between the stomach and the spleen and wouldn't encounter the situation. But if it is, I would press on it. We have to stop the bleeding first before we can proceed to the next step.
Thanks, Ken. Naranon, prevention is very important. Yes, stay the section next to the stomach, very close to the stomach, or keep some part of the stomach with the vessel. So thank you. And you're also having us the advice to expose to that part and then try to control it. First thing, to keep ourselves blood pressure down, heart rate stable. Thank you very much. Let's see, Asim, what would you advise after having this situation?
So I guess what Ken, Ramesh, and Prof said are absolutely true. First of all, choice of energy devices. In people, generally I find bipolar much more smoother. And the whole answer to that is that the ultrasonic devices, the active blade actually results in waves that move right in front of it, right? So even the moment you put it next to the spleen, it will blow a hole in the spleen. Okay, it may not necessarily destroy the vessel, it blow a hole in the spleen. So I personally have moved away from using ultrasonic devices for my splenic, for my sleeve gastrectomies. Now, the second thing is, if you were to lift the stomach, the greater curve, at a slight angle away, that is, means you lift it anteriorly and a bit towards the right side of the patient, it will then create an angle between the vessel and the spleen that you can see. And you can remain safely on the side of the stomach and take that vessel instead of leaving it lax and going close to the spleen and getting that injury. I would perfectly agree that if I have to sacrifice, I will rather have a hole in the stomach which I can stick rather than having the situation that you have landed up in, which is bleeding. If I do land up in bleeding, my first response is take a gauze, put on top of it, just get somebody to hold, wait 8 minutes. 8 minutes is the clotting time that you need to form a clot. Let it bleed a bit, put enough pressure on it, the vessel will go into spasm, it will stop bleeding. Do not try to do anything funny in there, like going after with an energy device, because the next thing is you will blow a bigger hole in there. Okay, be patient, hold on your nerves, tell your anesthetist you have a problem, they should get ready to catch up with, okay, and then just wait for 8 minutes with the pressure on it and slowly take out that gauze and it will go away. Then you can find what exactly is the problem and deal with the problem on its own merits. If you run into even bigger problems, use flow seal. Within a hemorrhage, it will actually result in a clot formation. Ultimately, all bleedings will stop. It's a matter of 2 liters, 4 liters, but you don't have to go there. Use something and halt the bleeding. Okay, worse come to worse. You cannot control the bleeding. The splenic artery, get control of the splenic artery. Snap the splenic artery, the superior polar branch, because the splenic artery branches into the superior inferior polar branch. The superior polar branch can be seen very easily. Isolate it after holding the splenic artery in your hand and infarct it. The moment you infarct the superior polar branch, the top part of the spleen is all black and you can keep the rest of the spleen. All right, so always know where to find the celiac axis, way to isolate the splenic artery. Just go for it and don't try not to go for heroic measures like going and putting stuff there and clipping blindly, because you just create more trouble. Thank you.
Thank you, Asim. You detail us very in step. So then I think if anyone in this room having this situation, to be keeping themselves through the problem without less problem, would say that. Let's see, Kazoo, you're super expert, super skillful surgeons, and also do you going back to the suturing or whatever your advice? Kazoo, thanks.
It's just like other surgeons, other experts, just grasp the breathing point. If possible, grasp the breathing point by your left hand is better. To control the breathing, to using a right hand is easier. And I'm not like Asim. I cannot wait 8 minutes. 8 minutes is too long for me. So I try to stop the breathing. And so the important thing is do not do the blind things. The blind things may happen the more breathing. So that always have to focus on the breathing point. To check where is the breathing point, check how is the breathing, and that is very important. And as Ken said, keep calm. All breathing can be stopped. So that the important thing is trying to check where is the breathing point and try to grasp the breathing point and calm down. That's the first things I always do during surgery.
Thank
Not
you.
8 minute waiting. 8 minutes is too long.
Thank you. So I think, yes, it depending on skill that you're going to deal with the situation. Anyway, you should choose the advice that match to your expertise. So anyway, let's have Professor Lee to conclude on this part before we move to the next.
I think the Asin has mentioned we need to know harmonic knife. The power is coming from the tip. So if you look at the video, actually the operator stand on the right side of the patient and the instrument is straight coming from the right side. So it's aiming at the spleen. So it definitely will cause the injury. And if you want to change the direction, you will need to pull the stomach lateral. That will tear the spleen. So I advise next time you should come in from the left side of the patient. So you are not aiming at the spleen. You can avoid this kind of the injury. But remember, when you go into the EC junction, you need to watch out the esophagus. I see some patients also injure the esophagus using harmonic because they forget the power is from the tip. So what you aim, you will injure that things. So that's my advice. Yes, thank you.
Thank you very much, Prof. I think, yes, all valuable advice is very important, especially how to deal with the angle of his actually the splenic area of the dissection of the devascularization. So let's be careful and try not to get into this situation. And advices are very valid to prevent. So please adjust or modify the technique to be preventing the potential bleeding, which not our friend, right, Ramesh, as you said, bleeding from the spleen is not friendly anymore. So anyway, I think we follow our advice. Let's see a bit for the video, Naranon, how we deal with quickly, and then we move to the next.
Okay. Just one last comment that I would like
Please,
to. So
Asim.
once you start having bleeding, okay, then just stop your energy device there. All right, and take a cool back step and think. You know, I've done this myself, so I'm very glad that you guys shared this. When it's happening, then you in a haste try to do more. You use the energy device more and there is more harm. So I really like to reiterate Kasama's point. Chill back, relax, think. You may not want to wait, but don't do things blindly. The last I did, I cut the vessel, and the whole, instead of half the vessel bleeding, the whole vessel was bleeding now. I had a bigger problem at my doorsteps, right? And I could not control the vessel because the vessel was flipping like this, rotating in the air and spilling blood all around like a helicopter, right? So you don't want to go there. You know, you want to say, okay, damage control and bail yourself out. So thank you for that comment. And I really love to see what you did.
Thank you for emphasizing the initial step of dealing with this situation. Asim, thank you very much. We don't want to get into that very worst situation. But anyway, thank you. Naranon, just going to the point and then we move to the next.
Okay, this what will happen next. As shown, we try to clean the bloody field with suction. As you see, it's still active bleeding. So we use the gauze to compress it at the bleeding point and clean, compress and clean around blood clot and compress it and try to control another bleeding at a smaller. So then the next we continue to do the gastrectomy. And we use the Surgicel to help us to compress it. And now we continue to do the sleeve gastrectomy. After we finish, we recheck again at the bleeding points, and you see it's slow down. And after it slow down, we try to direct stop bleeding at the bleeding points, and our bleeding is completely stopped.
Okay, Asim, any comments?
Thank you.
So that was great. I think what you guys did was absolutely right. Can I just have the last picture, the last frame of your movie? So what you see is after you have burnt the middle vessel that's supplying the middle, it has, you can see here that the middle section of your spleen has gone ischemic. Okay, so essentially the middle vessel is, you have basically, when you have done the hemostasis second time, that vessel you have taken out. Okay, so that's why the spleen is now congested in this area. It's ischemic, which is perfectly all right. Okay, you don't have to worry about anything. And I think you guys just did a marvelous job. I would never myself chase it into the hilum of the spleen, because as you go further and further, it just becomes more and more difficult. Suturing, I think Sutep said, I'm not Kasama, so suturing is not my pain, so I don't suture. I'm a clip person, and clip whatever comes your way, and if you can't, then I rely on aids like Flow Seal, like Surgicos and Surgicel to control it. I'm a bit more generous with packing. I think if a couple of gauze create a weight, the clot formation is a bit more, and I would have put an assistant port to continuously press there and not take off the pressure. So that's something that I might have done differently, but well done. You got off the hook nicely.
Thank you, Asim. I think we have learned a lot from our expert here. So, but because of time, so let's move to the next, which is going to be more interesting. So let's have Narong. You have something to share with us, which is very, very interesting. Please, Narong. Narong is from Bangkok Administrative Hospital or Klang Hospital. Narong, please.
Hello, everyone. Patro will present this case. Thank you.
Good morning, everyone. I am Dr. Patros. I would like to present the case from Dr. Narong. Share screen. Okay, I would like to present this case. It's a female, 37 years old, with morbid obesity. Her BMI was 37.8 kilogram per meter square with comorbidity, hypertension, dyslipidemia, and impaired fasting plasma glucose. She has the past history of balloon insertion for 3 times. At the first time, at 5 years ago, at that time, her body weight was 86 kilograms. She underwent the first time intragastric balloon insertion for 9 months duration, and she can lose her weight down to 55 kilograms. After that, at 3 years ago, her weight was regained up to 84 kilograms, and she decided to undergo second time intragastric balloon insertion for 11 months duration, and she can lose her weight down to 60 kilograms. After that again, at 10 months ago, her weight was also regained up to 91 kilograms, and she still decided to receive the intragastric balloon insertion for the 3rd time for 8 months duration. But this time she can eat the same and could not lose her weight anymore. So at 2 months ago, the balloon was removed and she came to visit us this time to undergo the laparoscopic sleeve gastrectomy. In intraoperation, the intraoperation we found that the stomach wall was thicker than normal, especially at the mid to distal part of gastric body. It seemed much more thicker than normal as shown. The first stapler, the green color stapler, was fine, and we found some blood oozing and serosal tear at the end of staple line. The second stapler, we used the green color as well due to the stomach thickening. And we found serosal tear along the second staple line. The third stapler, we used the green color. And the fourth stapler, we used green color as well due to stomach thickening. After that, the stomach wall thickness was normal, so we used the blue color stapler for the remaining. After checking bleeding, we found serosal tear along the staple line of the first and second stapler. So, what would you do with this problem, the serosal tear along the staple line like this? Please vote the poll. The choice, no need to repair, or suggest to repair by suture or repair by glue, or others, please suggest. Thank you.
Thank you. Please join us for the advices in this situation. But I know that you may have a lot of concern and a point of discussion. We will do that later on. So let me have the answer. Okay, most of us would say you should do something to take care of that part. So let's have Asim. I know that you are the person that very carefully choosing the height of the staple line. Also, you may discuss about other part of this case. Asim, please.
Okay, thank you, Sute. So first of all, multiple intragastric balloons. So it's almost like treating somebody, in my mind, with somebody who's had a gastric band, right? So absolutely right, as Sutep said, please use a black reload staple, all right? And that's something I would do. I would wait for longer periods of time so that fluid distribution is leveled. I will fire my staples slowly. I would use a stapler that gives me a homogeneous compression one time versus a sequential stapler, which basically narrows down to the apex, which then tears the tissue at the apex. Unless obviously you can match the height of the staple. If I find that my patient's stomach is very thick, I give them intraoperatively Buscopan. It relaxes the smooth muscle. It allows you to flatten the tissue, and that basically decreases your compression height, which then you can mostly come up with a black or a green reload, and you would do this. If I find that despite all that, I have sequential tears at the apex of my staple, I stay away from my bougie, complete my sleeve, and stitch my staple line at all those crotch points. Okay, remember, when a staple tears, what it does is it only staples at mucosa, and the gastric mucosa does not have mechanical strength. The strength of the stomach lies in its serosa. So that's what I would do, Sutep. So I'm great that you showed that movie. Thank you.
Thanks, Asim. Ramesh, advice to Pataros?
Yeah, I think the choice of staplers is very important, and probably due to the multiple intragastric balloons, the stomach is very hyperemic, very thick. So I think your choice of stapler is very important. And if the tears are obvious, I think the safest would be just to suture them, because you would just spend a little bit more time on your surgery, but end of the day, the patient is safe. So I think that's the most important step in preventing leaks in this kind of patients. Yeah, thank you.
Thanks, Ramesh. Ken, any advice on the managing processes or what to do with this one in this case situation?
Yeah, I do gastric balloon myself. So this is very interesting because I think you can almost anticipate it by when you're handling the stomach. So if I routinely use black cartridges, the thickest one, and I also routinely, besides the first shot, using buttressing material, which often helps. But this is probably the time that you leave the sleeve a little bit loose. In terms of suturing, I think, you're not oversold only. You can do two things. I think I would do two things in this case. I would invert the staple line so that you bury the staple line. And then I will suture omental fat on the outside as a second protection if you don't use buttressing material. If you have buttressing material and it tears, then possibly I would just tack omentum on top of it as a covering. But as Asim pointed out, yeah, serosa is your integrity. Mucosa give nothing, and they will blow, and then you have a perigastric abscesses, and you'll be managing it. And routinely, actually, I wait for 3 or 6 months to actually do the sleeve, because that will allow the stomach to recover. But this particular situation also can happen in male patient, older patient, and also like diabetic patient, because I found that diabetic patient also, the stomach, they have gastric emptying problem, because what the balloon does is essentially producing delayed gastric emptying, and there's always weight training of the stomach to the balloon, so the stomach wall gets thicker. So just like they try to squeeze the balloon out, so that's why the stomach wall is thicker, if you think about that. And the patient often don't tell you. They don't classify a gastric balloon as an operation. You ask them, have you had an operation before? No, I haven't. And then you go in, then you find, oh, maybe you have probably had the balloon before.
Thank you very much, Ken. Thank you. Advice was saying maybe three to 6 months after having the balloon removed. And also, Asim, the technique of using Buscopan or something to flatten the loogie also very much very good information. Kasu, I think Narong has been preparing the situation for us to be back to the suturing. Could you give some advice?
Okay, so just like other experts, the most important thing is the choice of the height of the stapler. For that, I always use the black stapler for the first shot of the sleeve gastrectomy, not related to balloon or not. Okay, and probably for the balloon patients, I usually use the black stapler for the second stapler too. Usually for the sleeve patient, I use a black one and then green and then gold. But for the balloon patient, I usually do the sleeve gastrectomy after 1 month after removal of balloon. And then at that time, I use 1 and 2 or 3 black stapler instead of other colors. And also in this situation, as a step and others say that the important thing is the suture. The suture, all the step line, you have the ruptures, and also that you need to hide all the tearing point by suturing. So that the suturing technique is very important when you do a bariatric surgery for recovery, for safety.
Thank you very much, Kasu. Thank you very much. You emphasize that the skill sets need to be there for taking our situation. Hopefully, please advise before we get to the next
Remember to make sure you have a black one before you're doing revision or bend after surgery. Yes.
Thank you. Very, very straightforward and very beneficial. Now, Rong, any comment to yourself and any advice to others in case of experience?
Thank you for every comment. I have to confess that at that time, I didn't have the black one spare in the operating room. So after this case, I always spare the black one for safety. Yeah. And in this case, I try to, I staple a little bit wider because I prepare to suture later. Yeah. And next time I will wait longer. Thank you.
Anyway, Narong, Kasu also having your advice that if you can suture the staple line, even 1 month after having balloon removed, you can safely doing the sleeve gastrectomy, right, Kazu?
Right.
So the time period also having need to have more evidence to support, but anyway, it's still the practice that you have to make the best in that situation. I think Asim have to have something to add. Asim, please.
Yeah, thank you. So I think, Sutep, something, because you have a lot of juniors that I see on the board. When we fire staples, our staples should be horizontal to the two surfaces. Okay, so if this is my staple jaw and I fire, it should be in this horizontal plane. Do not torque your staple this way or this way. When you torque, the staple formation at your end is not nice. And at the point of torque, there is more tension. It splits the tissue. So when you torque, when you put, always stapler flat. And this happens mostly when you try to push the pot higher. The angle at which your stapler comes does not match the angle of the tissue. So if you heard Professor Vijay Lee comment very early out that you should put your port such that the tissues are met with the staple or energy devices at the correct angle of the tissue. If you put it this way and torque your tissue, then you're likely to result in a tear of a tissue, which is the chances are higher. So always try and prevent that torque. I know a lot of people in the audience will say, okay, use buttress material. Remember, buttress only, to me, adds to trouble. All right, because you can't now, when you open the buttress, you need to look inside where the tear was, and then it becomes more and more complicated. Buttress materials will stay. If you have an infection, they will promote infection. So be careful when you use buttress, and always oversize when you use buttress materials.
Thank you, Asim. Thank you for the basic but very important skill set that you have to be familiarized with the stapler that you are going to use. So thank you very much. So I think, thank you, Narong. It's very interesting, very challenging. So let's move to the next, which is going to be presented by Dr. Warabut, please. Dr. Amon Rat will give the presentation. Amon Rat, please.
Good morning, everyone. I'm Amarat Lewatrakan, second year clinical fellow from MS Unit Sirat Hospital, Mahidol University. Today I will present you the fifth case. This patient is a 20 years old man. Morbid obesity, BMI was 48.4 kilogram per meter square with underlying of severe OSA and thyrotoxicosis. We schedule him for robotic sleeve gastrectomy. Here is the operative video. Between the staple firing, the cross staple was removed. There was bleeding after the third firing. After section and evaluation, the finding was shown as the video. The poll was, what should we do next?
Thank you, Amonrat. Please join us for the managing point. What should we do?
The first was a crusher defect with another stapler. The second was a crusher defect with another stapler and reinforcement suture. The third was a crusher defect with handsaw single layer, and the fourth is the crusher defect with handsaw double layer. Thank you.
So I think, thank you, Sierra team, for having us a very beautiful case of robotic sleeve gastrectomy. But anyway, the problem now was the stapler that was not formed nicely as we expected. So what should we do? So let's have the answer of the poll. Very good. Mostly would close with handsaw single or double lay. So please follow proceed for the next Amonrat, please. Okay, so I think we come to this point of discussion. So let's go to Ramesh in this situation that you have firing the stapler, but we can see the opening.
Yeah, I think the opening was quite obvious on the video just now. I guess sewing hand sewn with probably single or double layer would be quite sufficient to hold to close up the hole actually in this procedure which was done. My worry is if you use another stapler, you might not have enough space, or you might narrow the stomach even more, and that pressure buildup could cause more trouble in later on, because if you have stapled over another area and you narrow the stomach, I think that'd be a problem. This is a clean, I mean, it's a well-prepared stomach, so I think suturing and probably the single or double A would be quite safe, which I think I feel it would be quite safe. Yeah.
Thank you, Kasu. I think also this situation, you need to have a good skill on doing to deal with this situation. Please advise.
Yeah, I'm totally agree with Ramesh. So if there is enough space, we can do the double layer suturing. But if there is only a few space for suturing, we have to do the very careful single layer suturing. And I think it's okay. So the stapler is just a stapler. Do not rely on too much on staplers. So that we have to have some suturing skill always.
Thank you. Very emphasizing on that part, that suturing technique is very mandatory for everyone. So let's go to Ken.
Yes, looking at this video is already quite near to the fat pad, which means that there's not much space. If you're going to staple, you won't have enough. So if it's purely to reinforce it again, you know, suturing with tagging of omentum should be enough as well. Yeah, that's my thought. Yeah.
Thanks, Ken. I have seen Asim trying to, you know, advise more, especially other parts. Asim, you also robotic surgeons. Please give advice.
So it's interesting, and I'm very glad that staple misfire is extremely uncommon. And the worst ones are where the staple also gets stuck, you know. So I must say that you were lucky enough that the staple opened up and came. Otherwise, sometimes it gets stuck and you're like, get out, and it doesn't want to go off, right? So you basically have to switch off. If you're using a robotic device, if you are a powered stapler, you need to switch it off, put it back, use a jaw to open it up and struggle, but you can get it open and extract it. I think sort of one important thing that we need to advise as trainers is how do you close the defect. So if you see you're so close to incisura, if you try and close it in 2 layers, after edema happens, the whole of a 36 French bougie or a 38 French bougie will become very narrow. I would, instead of suturing it along its longitudinal axis, I would suture it along its transverse or horizontal axis and create a little bit more baggy type thing at the incisura, so that I don't get a post-operative stenosis. So instead of closing it long, I would close it on its width size. So doing like a duodenotomy and closing it that way, something like that. That's how I would close it. I would close my mucosa first, and that is just to make sure that I don't bite deep enough. And then I will close with a lot of relaxation, starting from both corners and coming to the center line, close my seromuscular layer. I would, in this patient, leave a nasogastric tube for decompression to allow for decompression. I would not feed this patient early. I would warn this patient to go very slow with diet, probably liquid diet for a long period of time, like a week, before I even initiate solids. And this patient is one who I would keep on proton pump inhibitors for some time to allow complete healing in order to prevent infection. So that's how I would do my side.
Thank you, Asim. Very much in detail, like we can follow step by step. Thanks. Professor Lee, any advice?
I will continue sleep first. I will finish my sleep. Then I will go back to suture, as they say, probably in 2 layers, 1 whole layer, then second is reinforcement. And consider to put the NG tube at least for 48 hours, as Asim said. You need to decompression for longer period, and that will be okay. Yeah.
Thank you, all advices. I think we are eager to see how Warabut, Monrad and team dealing with this situation. Could you proceed for the procedure that you have done? And also we would like to have a comment and experience sharing from Dr. Warabut.
After the thank you for your wonderful advice. After suction and evaluation, the defects was closed with hands-on single layer for contamination control. Then the operation was go on. The next stapler was applied then to complete sleeve gastrectomy. And the defects was sutured with vicryl between the previous stitch. You will see the defects was secure closed. And then the defects was reinforced suture with the continuous suture. Then the defects was completely concisely closed, and the postoperative EGD found no defect. Thank you.
Thank you very much, Monrad. Beautiful cases. And then what about we have to have your expertise in dealing with this situation, please.
Right. Thank you very much for all valuable comments. Well, actually, I experienced a couple cases of stapler misfiring when I was a bariatric fellow. But actually, this case, to be honest with you, it was my first experience since I finished my training. And then, if you look back in the operative in my operation, after complete gastrolysis along the greater curvature, I let my assistant to start transection of the stomach. I did use 2 black cartridge for the first and second file, and then after that I changed to the purple cartridge to the third file, and then I try my best to remove all the crotch staples and make sure that the symmetrical traction in the horizontal axis, and then try to make sure that I create not too tight sleeve tilt by using the 36 French bougie and not too snug on the bougie side, and then try to wait for 15 seconds before I start my third file, and then go slow. Use the electronic power gun, and then when I sat at the console, so I let my assistant find the staple. This is not the robotic staple. So initially when I start the staple, and then I noticed that the tissue of the stomach was pushed forward, upward, and then I knew that, oh my God, this happened again. It's like a bad story in my life when I was a fellow. And then but I couldn't stop it because I was out of the operative field. So I just wait until the process finished. And then when it happened, my fellow was shocked at that time. And then, I told my fellow that, calm down, stay cool, stay calm, and then don't panic. Okay, would you please put a little gauze inside? And then I just compressed the defect, and for a couple minutes, and then after that I removed the gauze, and then the bleeding slowed down. I can clearly saw the defect nicely, and try my best to remove all the malformed staples as much as possible. And then at that time I decided to close. I put a couple stitches at the defect first to make sure the outline of the staple, previous staple is here, like here. And then I continue doing more firing for the rest of the stomach. And then I come back to put a couple stitches more to make sure that's 100% closure the defect. And then I realized that my sleeve is not that tight at that time. So that's why I put another running suture by 3/0 Wheelock's continuous suture, cover the defect. Just only this part. I did not do like the whole running cerebromuscular stitches along the staple line. Probably other expert can comment at this part. And then I put a little omentum on top of that. And then once I finished the operation, I did the upper endoscopy and it review narrowing or stricture or leakage could be detected. And then the patient went fine and then could be discharged home uneventfully, finally, yes.
Thank you very much and congratulations. So you have done.
But actually, I would like to hear from the comments from other experts, because I have been thinking, what happened? What is the cause of the misfiring in this patient? But I couldn't find the cause of the misfiring. Probably, maybe I chose. Maybe I probably should choose like a thicker, maybe a black cartridge for the third firing, probably, and probably maybe wait for a longer time, like a pre-compression, maybe longer. I don't know. Maybe I would love to hear the comments from other experts, please.
Thanks. I think Ramesh would give you some advice. Any more advice from the panelists?
Yeah, I think the choice, like I said earlier, the choice of the stapler is one. Removing the other thing is the crotch, where the crotch of your first staple line, making sure there's no remnant staples left there at that point, which I think is, although it's very small, may cause problems that he has faced before. Yeah, I guess these are one of the few points which I have.
Thank you, Ramesh. Any more comment from the panelists or from the expert here? So I think we congratulate you on the situation that happening, then you manage it nicely. You tailor the technique and skill into the patient to get the patient out of the problem, and it been shown from the result that it was uneventful afterwards. So congratulations, and we would love to have your expertise to share for the next time too. So I think we still have one more case to go, which I would say that it's also very interesting and very much good for discussion before, at least here for lunch. So please go to the south of Thailand, and it will be given by Dr. Lalida and Dr. Kamthon from Prince of Songkla, please.
The next case, a 34 years old female with BMI 56.6. She underwent the laparoscopic wrong-wide gastric bypass operation.
Sorry, Lalida, can you go to the slideshow?
Oh, sorry.
Thank you.
A 34 years old female with BMI 56.6. She underwent the laparoscopic wrong-wide gastric bypass operation about 6 years ago. And the problem during the operation was wrong-O misconstruction. In our institute, we do the wrong-wide gastric bypass, but from creation of the gastric pouch, and then we measure the bowel from the DJ junction for 100 to 150 centimeters to create the gastrojejunostomy anastomosis using the linear stapling technique. And then we cut the jejunum off to use as the BP limb. And after that, we measure the limb for create the wrong-wide configuration. And we close the mesenteric and the Petersen defects in the last step. In this video is after creating the gastric pouch and measuring the small bowel from the DJ junction. In this part, we use the GIA stapler to create the gastrojejunostomy anastomosis. And then we cut the jejunum using the stapler. And after that, we measure the bowel from the DJ anastomosis. And when we measuring, we found that the bowel is going into the Petersen defect and couldn't be pulled back. And so we decided to orientate the bowel from the DJ junction again because we suspected that we might have done something wrong. And here you can see the incorrect anastomosis between the gastric pouch and the BP limb. It was the wrong-O misconstruction. The error occurred when we use the jejunum to create the DJ anastomosis. There was the alternation of the proximal and distal part of the jejunum. So we have cut the limb from the gastric pouch, lead to the wrong-O configuration. And we have a poll asking asking for your opinion. If this case happens to you, what will you do to correct this error? First, connect the wrong O to the distal limb of the jejunum as the picture. Second, refashion back to the correct Roux-en-Y configuration. The third, reversal to the sleeve gastrectomy. And the last, consult or refer to an experienced bariatric surgeon. Please.
Thank you very much. Very interesting case, Larida. So then what should we do next? So can we have the result of the poll? You go, Lalida, the advice you, okay, so could you please proceed?
The result, the participants, mostly of the participants choose refashion back to the correct Roux-en-Y configuration.
Thank you. Let's pause a while, and then Warabut, I think you're familiarized with the technique very well. Could you give advice for us on this point? Warabut, please.
Well, basically, I would to reroute the anatomy. I mean, we can start with the transection of the gastrojejunostomy, and then that's become the below pancreatic limb. And then you can put another stapler across the JJ anastomosis. Oh, no, sorry. In this case, we didn't perform the JJ yet, right? So we just find a stapler across the JJ anastomosis, and then that's become the BP limb. And then we can reroute the anatomy, and then put bring the Roux limb, the true Roux limb, up to the gastric pouch, and then you can do gastrojejunostomosis, and then after that you can do JJ. Yeah.
Thank you. Ken, any advice in this situation that you misarranging the anastomosis?
I think the best is start from scratch if we can, because it's always very confusing. And if you restaple it and restore anatomy first, take a deep breath. I think you can start from it first. If you do anything different, then there will be peristaltic problems later, and then you may encounter it. I think a standard operation is a standard operation. I would say just take a deep breath. It might take you a bit longer time, but restaple, restart, but make sure you work out all the limb. And sometimes you can use marker to actually help you. You can use marking pen to try to give you some hints so you don't get too lost. That would be my advice. Or put suture on it. Yeah.
Thank you. Ramesh, advise Lalida for the next step, please.
Yeah, the reconstruction is definitely the step forward. I was quite interested in one of the options which says refer to a more experienced bariatric surgeon. I think for junior doctors, I think that is very important to get advice and not to to decide there and there what should be that person's next step. So getting an advice from a senior person, I think helps a lot, because you don't want to convert this to another surgery and end up with problems later on. And I think as what Ken says, marking is very important. So because sometimes you got so much of bowel and you're not sure, if you're a junior surgeon, I think these mistakes can happen. It's not something wrong, but I think marking your limbs with either the suture or marker, it's very advisable. Yeah. Okay.
Thank you, Ramesh. Asim, this situation now need to have some advice, please.
So I think firstly, if you practice this way of doing a Roux-en-Y gastric bypass, when you are counting your bowel, never bring the camera into a zoom position. Okay, you must always see two graspers moving in the field away from the operating field, because what happens is you bring these two graspers and the camera is right up here, and then you've picked the lower bowel from the other side and you're going the wrong way now, right? So this switch of hands switch of camera should never happen without you seeing very clearly. I have done it. Most of us would have done it and been there. What I find that I made the mistake is that when you're doing this, I stopped depositing my bowel in the left hypochondrium. Right? So normally take left hypochondrium, take left hypochondrium, take left hypochondrium, right? So it's when you move roughly around and pick a drop loop of bowel, that is when you make the mistake, and especially if you're very zoomed in. What to do? I will complete my Roux-en-Y bypass, but I would do a hand-sewn gastrojejunostomy. The first advice is, if you do not know how to suture and you do not have an expert, do not do bariatric surgery. Okay, because you land yourself in trouble, you are asking for some serious trouble. Yeah, because it's not easy to open this guy up and do a hand-sewn conversion, right? So please be very skillful in suturing. Get yourself mentored is my advice. Thank you.
Thank you very much, Asim. Professor Lee, how to prevent and how to deal with this situation?
I think Asim has mentioned the important point, and this case is quite lucky because you find it before you're doing an enterostomy. Otherwise, the situation will be very complicated. I had one case in my one anastomosis. I do the same thing, but because one loop anastomosis, you don't need to check below. So we find it, I think 6 months later, patient become malnutrition. Then we go inside, we found, okay, we make a turn. So the common channel make only 2 meters. So this is the same situation. We need to take care when we measure the bowel, always in the same direction. Yes.
Thank you very much, Kamthon. Please share us your experience in this situation.
Yes, thank you everybody for your comments. In this case, it was sure. This is about 6 years ago when I started to do biotic surgery. This is my just beginning. In this case, honestly, we don't find a video before this, but I can tell you that this is my fault because I lost the bowel during measuring the BP limb out of the visual field, and then I thought I picked up the long side, and then I count until and then make the long gastric bypass GJ and then DY, and then this problem will happen. For these cases, fortunately, that Asim said, we found it intuitively. Okay, so we can solve it now. So for some cases that I have been consulted from our colleague outside, do the same, but we found that after operation, that case have a leakage of the GJ and patient have the bilious vomiting. So it's difficult to deal with that case. So for this case, after that case, we try to execute our strategy to prevent the Luong-O misconstruction. By every case, we have to identify DJ junction, clearly seen DJ junction, and not lose the bowel during measuring, and the bowel always in the vision until we make a GG anastomosis and divide jejunum. And also, I think I routinely do the iridescent defect closure or defect closure. If you do the correct configuration during the closure of the defect, you will see the GJ junction inside the defect, right? Yeah, and you close it. And the last step, we will check it again. That's the Luong-Y configuration is right. And after that, we're not facing with this problem again.
Thank you for your very interesting case. Lalita, you would like to show that video shortly, and then I think probably have something to share to us just a while. So Lalita, please.
case, we choose the refashion back to the correct wrong Y configuration. To correct this error, we separate the BP limb from the gastric pouch. And then we perform the suture marking on the BP limb and took down the wrong anastomosis. And after that, we create the correct anastomosis between the limb and the gastric pouch by the totally hands-on technique. And after that, we create the JJ anastomosis and close the mesenteric and pedocentric. Thank you.
Thank you very much. Congratulations to Lalida and Kamthon for this very beautiful case. Actually, you detected intraoperatively and you deal with that situation nicely. So that's why the patient doesn't have any effect much. So I think we still have a couple more minutes. So probably we would love to learn from you a bit because you have something to share to us. Please, Professor Lee.
You mean to comment the section of today?
Actually, you have something to share to us if you have time, but if not, yes, please proceed for.
I think it's already past our time, so maybe we will skip the case to next time. Yes.
Okay, that's great. So let me before closing. Yes, I would like to thank again all panelists for your contribution. Thanks Azim, Ramesh.
Yes, thank
you. Ken, very much and special thanks to you. And also Kazu, who have left already because of his commitment to another one. And also thanks all teams for preparing very beautiful cases. Narong, Kamthon, Pakawut, Warabut, and all fellows here who are having a very much great contribution. So let's see, the next one will be going on 23rd of October, and it will be, if not doing well interoperatively, we may have another challenge post-operatively. So then please follow us on 23rd of October at the same time. Before we going to Professor Lee to close, just have some message from Kazunori Kasamat. You have seen that the suturing is very important, so please also join us on Elsa and Jess's webinar would be on the November 11th for the super suturing webinar. So you can follow us on that session. And thank you very much. And also thanks Medtronics for your contribution. So before we leave, I would like to again have Professor Lee to giving the closing speech on this session. Prof. Lee, please.
I would like to thank Sutep and his team for this wonderful organization. For me, I think the program today is a novel creation, and I think it's really helped to the young surgeon. Also for me, I learned a lot. So thank you again, Sutep, and expecting the next section. Thank you.
Thank you very much. Thank Prof. Lee. Thank you for your leadership. Thank you. And thanks everyone. The panelists, please have us the feedback and what you would like to have. Please let us or our team know. So once again, thank you very much. Thank you.
Thank you.
See you next time.
Thank you. Thank you.
Thank you, our panelists. Please.
Thank you. Bye-bye.
Bye.
ขอบคุณครับ
ขอบคุณครับ Thank you very much. Thank you.
ขอบพระคุณอาจารย์ทุกท่านด้วยค่ะ
Thank you. Thank you. Thank you everyone วรบุตรขอบคุณมากนะครับ
ขอบคุณครับ
สวยงามขอบคุณมากขอบคุณมากพักวุฒิ Thank you กำธรสวยงามฮะต้องเรคคอร์ดไว้เลยเนาะของวันนี้เนาะ Thank you very much. Thank you all participants.
Recording stopped.
Okay. stop ละคุยได้เชิญขอบคุณมากครับขอบคุณมากสวยงามนะสวยงามของทุกคนเลยนะของวรบุตรก็สวยนะดูว่าจะแก้ยังไงเนาะจะเย็บก่อนแก้หลังแต่ว่านะคือทุกคนบอกหมดอาซิมบอกใช่ไหมเฮ้ยขอบคุณมากนะที่อยู่เอามาแชร์ว่าทุกคนบอกตรงๆว่ามีหมดอะแต่ว่าจะแชร์ทีนี่ด้วยแชร์หรือเปล่านี่แบบอะไรประมาณนั้นเข้าใจป่ะ
อันนี้ไม่ได้ถ่ายทอดเลยนะครับอาจารย์
ไม่ได้ถ่ายละไม่ได้เรคคอร์ดละถ่ายทอดอยู่ยังถ่ายทอดอยู่แต่ว่าไม่ได้เรคคอร์ดละ
จริงๆถ่ายทอดนะคะอาจารย์แต่เราพูดกันได้ไหมคะparticipantเริ่มทยอยออกแล้วค่ะ
มี attendance อีกสูงสุดเท่าไหร่วันนี้100 กว่าคนใช่ไหมอยู่ในนี้
วันนี้ออนเห็น maximum ถ้าเป็น attendee 90ค่ะถ้ารวม panelist เพราะบางทีเราอัปเกรดบางท่านเป็น100ค่ะ
ไม่เป็นไรดี
นี่ไม่ได้เป็นคนยิงเองใช่ป่ะเป็น
ไม่ใช่ครับชัดเจนไม่ใช่ว่าเป็นผู้ดีคือนี่นั่งอยู่บนคอนโซลฮะ
อยู่บนคอนโซลพี่แต่ว่าถ้าผมยิงเองก็อาจจะเกิดนะครับพี่จริงๆ
ไม่มีจังหวะอย่างเงี้ยมันมีจังหวะจึ๊กอย่างเงี้ยตอนช่วงที่เข้าไปแล้วมันมีจึ๊กอย่างเงี้ยมันเหมือนตอนปิดปากแล้วมันสามารถจะสะบัดได้ไม่รู้ตาฝาดหรือเปล่า
ต้องมาทดลองดูโอ๊คเดี๋ยวยืมของออนเอาของมาลองดูสิถ้าจึ๊กแล้วมันจะเป็นยังไง
ผมว่ามันมีทุกบริษัทนะครับ
ใช่
ไม่เกี่ยวกับเรื่องยี่ห้ออะไรเลยว่าจริงๆแล้วผมว่า
ไม่รอเดี๋ยวอาจารย์ไม่รอเดี๋ยว
ผมว่าไม่เกี่ยวกับยี่ห้อแน่นอนครับแต่ว่าผมว่ามันอาจจะด้วยมีปัจจัยอะไรบางอย่างเหมือนกันเช่นมันอาจจะหนาไปแล้วผมอาจจะใช้สีม่วงก็ได้แล้วก็แบบมันหลายๆอย่างอะพี่ผมว่ามันก็พยายามมินิมัล
ใช้สีม่วงตลอดเลยสีม่วงตลอดแนวเลยแต่ว่าของพี่มันเจอแต่หนืดแบบครั้งนี้มันดูสมูทตืดอย่างเงี้ยแต่ของพี่มันจะช้าประจำเลยแบบก็ไม่รู้ว่าทำไมมันช้าก็ไม่รู้
โอ้ไฟมันต่างกัน
ผมก็เจอเคสเลยนะเป็นเหมือนกัน
ไม่ช้าแบบช้า
ส่วนใหญ่ถ้ามันช้าพี่มันหนาด้วยครับพี่ครับหมายความว่า
ช้าจนแบบกูตัดไปบอกว่ากูตัด NG เหรอวะกูตัดบุ๊กกี้เหรอวะประมาณนั้นแหละ
ถ้าเป็นตัวซิกเนี่ยถ้ามันช้าเนี่ยแปลว่าที่ชูนข้างหนาพี่แปลว่าพี่
ช้าตลอดเลยจะแบบว่า
ช้าดีแล้วพี่
เอาไปเช็คเถอะไม่ไหวแล้วแบบวะอย่างเงี้ย
ไม่แต่ emphasize นะออนว่าอาจารย์วรบุตรพูดถูกต้องฮะว่าอันเนี้ยมันเป็นกับทุกยี่ห้อฮะแล้วก็ผมก็บอกทุกครั้ง
ค่ะต้องขอบพระคุณค่ะอาจารย์วรบุตรพูดดีเราฟังอยู่ว่ายังไงดีค่ะ
มันเป็นทุกยี่ห้อจริงๆครับอันนี้มันเป็นเกิดได้อยู่แล้วครับมันไม่มีปัญหาครับแต่พูดถึงว่าประเด็นที่ดิสคัสคือเทคนิคทำไงให้มันเกิดน้อยที่สุดนี้มากกว่าครับ
อาจารย์คะเป็นที่สีไหมคะเพราะว่าเห็นตอนแรกอาจารย์ใช้สีดำมาแล้วตัวที่เกิดปัญหาเหมือนเป็นสีไม่ใช่สีดำแล้วจะกลับมาใช้สีดำอีกทีก็
ปกติคืออย่างนี้ครับคือปกติเนี่ยผมใช้สีดำ2ตัวแล้วก็ที่เหลือม่วงครับส่วนใหญ่จะเป็นอย่างนี้นะครับแต่ว่าถ้าไปรีวิวดูใน human stomach จริงๆเนี่ยตรง antrum เนี่ยมันเฉลี่ยประมาณ3มิลนะครับตรง body เนี่ยประมาณ 2.5 ประมาณก็ได้แล้วก็ตรง fundus ประมาณ 1.5 อะไรเงี้ยครับคือถ้าให้ดูจริงๆเนี่ย close height ของตัว dry staple เนี่ยคือมันไม่เท่ากันนะครับคือถ้าดูเนี่ย outer ของไอ้ dry staple เนี่ยมันจะพอเรียกว่าหนาสุดสูงสุดแต่ว่าจริงๆถ้าให้ดูจริงๆอ่ะพอมันปิดจริงๆมันแค่ 2.2 2.3 อะไรเงี้ยมิลมันไม่ถึง3มิลอยู่ดีแล้วในตลาดมันควรจะ create แค่เป็นสีอะไรดีอ่ะสีลุ้งอะไรอย่างเงี้ยเพื่อให้แบบมัน
ขอเทคโน้ตไปบอก R&D นิดนึงค่ะ
ใช่แต่ว่ามันก็ไม่มีในตลาดแต่ไม่เป็นไรครับก็คือผมว่าตอนนี้ผมก็เลยรู้สึกว่าบางทีผมอาจจะลองเปลี่ยนเป็นสีดำเกือบทุกตัวยกเว้นฟันดัสเป็นสีม่วงอย่างเงี้ยอาจจะเพราะว่าก็ในลองไปรีวิวเปเปอร์ว่ามันพูดอย่างนี้ก็ส่วนใหญ่เขาจะมีของมิเชลการนี้เขาก็พูดอย่างนี้เหมือนกันว่าก็ดำหมดหรือที่เหลือม่วงก็ได้อะไรอย่างเงี้ยครับอาจจะลองดูครับผมว่ามันก็
ลองถามความคิดเห็นอาจารย์ดูค่ะว่า
เป็นความคิดเห็นส่วนตัวครับไม่
ไม่แต่ว่าผมว่าวันนี้ทุกคนพรีเซนต์ได้น่าสนใจมากนะแล้วก็เจ้าเสถียรพงษ์ผมให้คุณไปเรียงเคสมาถือว่าเรียงได้ดีนะก็ค่อยไล่ไปเสือสเต็ปใช่ไหม
ดีครับ
ค่อยแอดวานซ์มากขึ้นนะฮะแล้วก็เวลาคุมได้ค่อนข้างใช้ได้แล้วล่ะนะแต่ว่าคราวหน้าเดี๋ยวเป็นโพสต์ออฟนะผมจะเรียนอาจารย์ทุกท่านไว้ว่าก็เหมือนเดิมฮะไม่เป็นไรฮะผมว่าเราเอามาแชร์เนี่ย brave to share เพราะว่าเรา responsible เนาะก็คือมันเกิดขึ้นเราก็เอามาแชร์ให้คนอื่นดูแล้วก็ทุกคนก็ได้ advice อะไรไปซึ่งมันมีทุกคนนะครับนะแล้วก็คนอื่นได้ประโยชน์
เนาะเราได้ความรู้มากเลยอะค่ะ
ใช่มีคนเปิดกล้องมาแล้วเฮ้ยยังอยู่ที่คอนโดอยู่เลยอ่ะ
มีคนอยากร่วมค่ะ
คนอยากร่วมไม่หรอกแฟนเขาไม่ให้ยอมให้มาร่วม
อาจารย์กำลังบอกว่าถ้าเกิดว่าอันนี้อีเวนต์อย่างนี้ดีฮะถ้าเกิดผมจะจัดในนามของไทยแลนด์แล้วก็เชิญพวกทางอาจารย์ที่เป็นบริติกในไทยแลนด์มาจอยอาจารย์คิดว่าไงครับเพราะอันนี้เป็นของ
คุณบอกว่าไงคุณจะเอาไทยแลนด์อันนี้คือของไทยแลนด์เลยเราจัดให้
ไม่แต่ว่าจัดเซสชั่นพูดภาษาไทยมั้งคะใช่ครับใช่ครับว่า
ไม่คุณผมจะบอกคุณว่าคุณจัดอินเตอร์ให้มันบ่อยขึ้นคุณอย่าบอกว่าอาจารย์คนไทยฟังภาษาอังกฤษไม่ออกไม่ต้องคุณทำครั้งเดียวคุณทำครั้งเดียวให้มันจบฮะเข้าใจไหมแล้วก็ผมจะบอกว่าที่ดีก็คือเอาพวกเขา3-4 คนมานั่งแล้วคุยให้เราฟังเราเรียนเขาแบบเนี้ยประโยชน์คนไทยสูงสุดคุณออนครับนะฮะไอ้มันบอกมาเรียบร้อยแล้วเริ่มมันแล้วนะเข้าใจป่ะ เดี๋ยวจะบอกว่าเดี๋ยวผมจะบอกว่าอย่างนี้ครับคือเดี๋ยวเราลองไปแพลนนะผมว่าอีเวนต์ต่างๆเหล่านี้เห็นไหม Professor Lee เขาก็แฮปปี้มากนะฮะทุกคนผมก็แฮปปี้นะฮะทุกคน enjoy คือผมไม่อยากจัดย่อยๆลงไปอีกเยอะๆหลายอันนะฮะเพราะว่าผมว่าพวกเราทุกคนที่นั่งอยู่ตรงนี้อาจารย์ทุกคนเนี่ย expert เลยอะเนาะก็อยากให้แชร์ไประดับ international เพราะอาจารย์ต่างๆเหล่านี้เปิดประเทศเมื่อไหร่เขาจะต้องไปทุกที่เข้าใจป่ะแล้วก็ผมเลยมองอย่างนั้นหรือคุณว่าไง
ผมได้หมดครับอาจารย์ครับยินดีคือเราเห็นว่าในเรื่องของ education กับพวกนี้
นี่คุณต้องยืนมุมนี้เลยเหรอเพื่อเอาในหลวงมาข่มผมเหรอ
ใช่อาจารย์เหมือนรู้อ่ะ
ไม่เป็นไรเอางี้เลยเดี๋ยวเราคุยกันแต่ผมจะบอกว่าเป็นเซสชั่นที่ดีมากๆอย่างวันนี้มันปูพรมปูพื้นแล้วก็อาซิมเป็นคนที่ผมบอกแล้วว่าซิมให้ความรู้ดีมากนะละเอียดเข้าใจไหมให้มันลง
ชัดเจนค่ะ
อาซิมเป็นคนที่อธิบายได้ชัดนะฮะจริงๆของเราเนี่ยแต่ละคนอาจารย์ที่นั่งอยู่เนี่ยพูดได้ชัดหมดนะฮะแต่ว่าเราให้เกียรติเขาให้เขาโชว์ให้เราดูนะครับนะเพราะฉะนั้นเซสชั่นของเราผมว่าเดี๋ยวเราลองดูแล้วกันครับผมก็อยากจะให้ทำแล้วอาจารย์แต่ละท่านเรียกว่า contribute แล้วให้มัน massive ออกไปข้างนอกกว้างๆครับนะฮะมันเป็นการ introduce จังหวะเหมาะ2 ปีนี้เรามีโอกาสได้ทำเราก็ทำไปเต็มที่นะเข้าใจไหมเพราะฉะนั้นนะพยายามออนครับเรายินดีแล้วเราบอกออนไปนะออนเตรียมพร้อมนะปีหน้าเราจะจัดอีกฮะเดือน
ดีค่ะยินดีค่ะ
ครั้งยังได้เลยเข้าใจไหมถ้าเกิดเรามองว่ามันมีประโยชน์มันคุยได้อีกหลายมุมเลยนะผมบอกให้เข้าใจไหมในบาราติกนะฉลองกับการเบิกจ่ายวันที่1นี้เนาะถูกป่ะ
ยินดีค่ะอาจารย์ต้องขอบพระคุณอาจารย์ทุกท่านมากเลยค่ะ
ใช่มันเป็นเรื่อง knowledge ด้วยจริงๆอยากฝากอาจารย์วรบุตรทางอาจารย์กำธรนะครับแล้วก็ทางอาจารย์โอ๊คนะครับคือจริงๆเราไม่ได้จำกัดว่าจะทำแค่อันนี้เดียวนะฮะคือถ้าอาจารย์มีเรื่องของ education อาจารย์ยินดีบอกได้เลยฮะบอกน้องหรือบอกติดต่อผมโดยตรงเลยก็ได้ครับเดี๋ยวจะเข้าไป
นี่เป็น promise เลยนะอันนี้คือ promise เลย
ผมอยากจะให้เรื่อง education เกิดขึ้นนะครับอาจารย์ครับเพราะว่าเรา
ทุกคนทำได้หมดนะใน SISX-education เป็นนั่นหมดแล้วก็ทำในนาม Apmbss ได้หมดผมบอกแล้วว่าเราสามารถนะฮะcontribute ได้หมดเลยเพราะฉะนั้นคุณไม่ต้องรออาจารย์มาหาคุณเตรียมบัดเจ็ตไปให้อาจารย์เขาจัดได้เลย
Apmbss the president
thank you ไม่เป็นไรหรอกมันจะเพราะพวกเราแหละช่วยกันทำเนาะเป็นการปูพรมไปวันเดือน2023เนาะเข้าใจป่ะผมว่ามันเป็นการปูพื้นไปตรงนั้นนะเพราะฉะนั้นช่วยกันฮะคุณก็เห็นอยู่ว่ามันเป็นโอกาสเนาะเราก็เห็นว่านี่ก็เป็นโอกาสที่เราจะ contribute ได้นะเพราะนั้นก็คงร่วมมือกันไปได้นะโอเคนะมีอะไรจะเพิ่มเติมไหมนรงค์มีอะไรเพิ่มเติมบ้างไม่มีนะนรงค์
ไม่มีอาจารย์
นรงค์บ้านเสร็จแล้วใช่ไหมหรือยังนอนนอกบ้านอยู่
ตอนนี้ผมอยู่ห้องเรียนรูปเลย
โอเคขอบคุณมากนะครับ
ผมได้ระบบนิดนึงได้ไหมครับอาจารย์สุเทพ
ครับว่าไงฮะ
เพื่อนอาจารย์วิทูนะครับเขามาเหมือนกับถามเรื่อง pre-authorize ครับคือที่อาจารย์บอกว่า1 ตุลามันจะ active ใช่ไหมครับ
ใช่
คราวนี้คือมันมี 2-3 ข้อที่อาจารย์เขาแบบอยากให้เรามาช่วยกันนิดนึงคือข้อแรกคือว่าลิสต์รายชื่อหน่วยบริการที่รับรองโดยราชวิทยาลัยครับ
ได้เลยอันนี้เราลิสต์ไว้ให้ละมีเดี๋ยวส่งให้อีกทีนึงเนาะพวกเราทั้งหมดเนี่ยเราลิสต์มาละ
2ก็คือว่าระบบ registry ครับที่ให้มันล้อไปกับระบบของสปสชครับ
ของ ODS
ครับผม
บอกมาเหมือนกันฮะได้
ครับผมเหมือนกับว่าจริงๆมันมีเทมเพลตของทาง ENT ครับที่เขาหรือของ I ก็ไม่รู้ครับที่เขาทำกับสปสชอยู่เขาอยากให้เราเนี่ยทำให้มันเป็นในเทมเพลตนั้นเพราะว่าเหมือนกับซอฟต์แวร์มันจะ compatible ได้ครับไม่งั้น
ดีมากวรบุตรลองขอของ I เข้ามาดูนะเพราะตอนแรกเนี่ยพี่ให้ทางเราเนี่ยขอทาง ODS มาซึ่ง ODS มันไม่ค่อยเหมือนของเราเท่าไหร่ถ้าเป็นของ I ของเราจะดีกว่า
ผมได้ของอาจารย์วิทูลแกส่งมาให้แล้วครับอาจารย์
โอ้ perfect ดีเลยฮะดีเลยก็อันนั้นเป็นอันสำคัญฮะregistry ไม่งั้นเราก็ไม่เขาก็ไม่จ่ายให้เราเช่นเดียวกันนะครับ
ครับอย่างนั้นให้ผมลองไปดูก่อนไหมครับหมายความว่าอาจารย์โอเคไหมครับถ้าผมจะดูโอเคอย่างยิ่ง
compatible กับโอเคอย่างยิ่งที่จะให้วรบุตรไปช่วยดูเรื่อง registry ตามที่วรบุตรเคยดูไว้เนาะส่วนเรื่องaccredit สถาบันต่างๆเนี่ยเรา approve ทั้งหมดเลยพวกเราที่มีอยู่ตรงนี้นะฮะใส่ไปหมดละรวมทั้งคนใหม่ๆด้วยนะครับนะฮะเรารวมไปแล้ว
โอเคครับอาจารย์งั้นก็จะโทรมาเรียนอาจารย์ให้ทราบประมาณนี้ครับอาจารย์
เยี่ยมเลยคุณออนคุณได้ข้อมูลแล้วนะเนี่ยปกติเราไม่ให้ใครรู้นะเรื่องพวกนี้เข้าใจไหมคุณออน
หนูปิดหูหนูปิดหู
ป๋องด้วยป๋องเตรียมเงินไว้แล้วกันนะเพราะว่านะต้องเอาเงินผมต้องขออนุญาตใช้ล่วงหน้าไปก่อนนะเพราะว่าปีถัดไปมันคงจะเข้ามาเรื่อยๆนะอันนี้ต้องบอกอย่างนั้นนะมันจะได้ contribute ได้โอเคนะเดี๋ยวต้องไปศูนย์วัคซีนต่อขอบคุณทุกคนนะครับ
อาจารย์ขอบคุณค่ะ
ขอบคุณครับเพอร์เฟกต์ยอดเยี่ยมทุกคนยอดเยี่ยม
นะคะอาจารย์กำธรค่ะสวัสดีค่ะ
ขอบคุณมากครับสวัสดีครับสวัสดีครับ
แล้วกำธรเดี๋ยวผมโทรหาได้ไหมครับเดี๋ยวผมจะลงใต้ไปอาทิตย์หน้าครับอาจารย์
ค่ะปิดได้เลยค่ะ
โอเคค่ะ